I'd like to take this opportunity to provide an update on what's been going on in the Translational Neuropathology Lab in the last year. So I'm going to give you a little snapshot of a few projects which are currently running in the lab. The first is the SPRINTS project. This is our Medical Research Future Fund project, which was funded last year, and it's really based on the prevention of reperfusion injury and neuroinflammation following stroke. Now, we know that reperfusion injury can worsen outcomes following stroke because it can lead to brain swelling, increase in the stroke lesion size, and bleeding complications. All of these worsen the amount of brain injury and therefore increase the morbidity and mortality for patients. So what we're doing in this study is repurposing an existing drug to treat reperfusion injury following stroke. And that drug is befatubitant, which targets the NK1 receptor. Now, it's currently used in the clinic for chemotherapy-induced nausea and vomiting, but we're proposing using it to treat this deleterious complication of stroke in reperfusion injury. Now, currently, befatubitant is an oral formulation, so it's a tablet. And as you can imagine, that's not really appropriate for stroke patients. So our drug formulation and development team are actually developing an intravenous formulation that we can administer. So we have our fabulous team up the top here, our medicinal chemists who are really experienced in this area. So they are developing that intravenous formulation. At the same time, we're also doing some screening in small animal models. So we're screening in the mouse to see which formulation will be best. The team are developing a number of different options and will pick the most stable and the most efficacious to move forward with, to do a rigorous assessment in the mouse, but also in our large animal models in the sheep and non-human primates. Now, it is absolutely essential that we do this preclinical work. We can't just take this drug and put it straight into human clinical trials. We need to make sure it's safe and effective and rigorously screen it using multiple models to give us increased confidence that it will work when we actually progress it to the clinic. So we're currently doing the small animal work, as I said, the next steps of the large animal assessment, and then finishing up in the study with the clinical feasibility. So a phase 1/2A study to see if the drug is safe to give, which we assume it will be because it's being used currently. And the second thing is to see, is it feasible in the clinical workflow following stroke to give this agent? So stay tuned for more results in the coming years. The second project I'd like to talk about is on secondary neurodegeneration following stroke. And this is where we have loss of brain tissue that happens distant to the primary site. So here we have a stroke in the middle cerebral artery territory, a really common site of ischemic stroke. But what we also have is loss of brain tissue in other regions, and you'll see some of these highlighted with the colours here. We're really interested in the thalamus in particular, shown here by the circle. So this is brain tissue loss which occurs distal to that initial stroke site. This can occur for months to years following stroke, and it worsens outcome because it's involved in cognitive decline and the development of dementia. The big problem is we don't know what's driving this delayed loss of neurons, and therefore we have no treatment. So our lab is looking at two different avenues. We think that neuroinflammation and dysfunction of the blood-brain barrier, which is that interface between the blood and the brain, might be involved. And that's exactly what our PhD students, Shannon and Isabella, are looking at. We've got lots of data, but I just wanted to give a little snapshot here. I'll draw your attention to these circles here on each graph. What this is showing, at 1 month following stroke, we have an increase in the stroke hemisphere, so the stroke side of the brain, of IL-6 and also IL-1 beta. And these are both pro-inflammatory molecules which are released from inflammatory cells in the brain and those of the immune system in an immune response or inflammatory response. So what this tells us is that there is inflammation happening beyond that acute phase following stroke. And this is in the thalamus. So this is in a region far away from that initial stroke site. So it really does give us a clue that inflammation might be playing a key role. But we, of course, need to look at this in a lot more detail, look at longer time points, look at lots of different inflammatory markers. And the next key step is actually to look at neuronal numbers. We need to see is there neuronal loss at this site as well as the inflammation? And we also need to look at function and behaviour, in particular cognition, to see if this inflammation is affecting function. The third project I'd like to speak on is targeting mitochondria to treat reperfusion injury following stroke. And it's my pleasure to present this on behalf of Dr. Annabelle Sorby-Adams, who is a Team Neuro alumni and is now a fully fledged postdoc in her own right. So fantastic to see members of the group going on and being successful following their time with us. So this is a mitochondria here. You might not have seen a picture of a mitochondria or even heard that word, but they're absolutely essential for all of us. These are the organelles in the cells in our body which make energy. So they take the fuel which we consume, such as glucose, and with oxygen, they produce energy in the form of ATP. So you can imagine that in a stroke where the blood flow is disrupted and oxygen delivery to the brain tissue is impaired, this directly affects the production of energy. So we have decreased energy production, but we also get dysfunction and injury to the mitochondria. These things together lead to reperfusion injury in terms of creating reactive oxygen species and what we call oxidative stress. And what that means essentially is that these damaging oxygen species can damage all aspects of the cell, the structure, the proteins that do all the work, the DNA, everything. So this exacerbates the brain tissue injury and worsens outcomes. So in this study, we were really looking at targeting the mitochondria specifically to see if we could reduce that amount of oxidative stress and free radicals and therefore improve outcomes. So indeed, that's what we saw. So first of all, I'll draw your attention to panel B, where we have the neuroimagings. This is MRI. At 1 hour following stroke, we can see this white region here. This is the stroke infarct, or the amount of dead tissue. And we can see at 6 hours, just below that, that region is much larger. So the stroke has expanded as that tissue is continuing to be deprived of oxygen, and those neurons succumb and they die. So this is the natural progression of the infarct. However, when we gave either a medium dose here in the middle bar or a high dose of our novel drug targeting the mitochondria, we can see that we have a halting of the infarct progression. So this is with no treatment. We can see over time the infarct gets bigger, but with either of the treatment doses, either the medium or the high, the infarcts stop growing, which tells us we're saving the neurons and we're actually improving the situation following stroke. This is really encouraging. This was some pilot data, but Annabelle's just been funded with another grant from the NRF to actually finish this study and complete the numbers. So stay tuned for more, but it certainly looks encouraging at this point in time. And the last study I want to draw your attention to is the non-invasive measurement of oxygen in the brain. Now, current approaches are to use things such as cerebral oximeters, but these aren't particularly accurate. And then we also have invasive monitoring, where probes are put directly into the brain parenchyma or the brain tissue itself. These are very accurate, but as you can imagine, there are some complications or potential risks, including bleeding or infection. And we can only do this in certain settings because it is so invasive. So it begs the question, are there other technologies we could be using or other options that would give us more flexibility in terms of measuring brain oxygen, but not at the expense of being accurate and dynamic? So this is where the Cyben device comes in. Dr. Jessica Sharkey has been leading this project, who's also another Team Neuro alumni, which is fantastic to see. She's been working with Cyben to test the Cyben device. And this is based on the principles of pulse oximetry. And it's able to continuously and non-invasively measure brain oxygenation. So the device is just placed on the surface of the head and can actually tell us about the oxygen changes within the brain below that. So we wanted to know, how does this compare to the invasive monitoring? With any new device, it's essential to compare it to what's currently used in the field. So that was the purpose of this study, to compare the non-invasive monitoring to the invasive monitoring. Now, I just want to draw your attention, first of all, to the blue box. So at the top here, we have the brain output, the brain pulse, and the bottom panel is the skin pulse. Now, it's important to measure both of these because you imagine the sensors placed on the top of the head. And between the sensor and the brain is obviously the scalp where there's rich in blood flow. So we need to look at that skin pulse because we want to make sure that any changes we're seeing aren't due to changes in the scalp blood flow rather than the brain itself. So you can see in the brain pulse, we have a very different waveform to the skin, and we get these kind of oscillations, which are really reflective of the brain moving and shaking with high systolic pressure pulsations. So we see this with elevated ICP. So this was an encouraging finding. And what we did at the same time, so this is the output from the device, but we also need to do that invasive monitoring. And we were able to make this happen due to the generous funding from the Wilkins Family Foundation to purchase the Raumedic box and the probes. So we actually use the PTO probe, and this measures concurrently intracranial pressure, oxygen, and temperature. So that allows us to collect all of that data just by the insertion of one probe. And these probes are actually used clinically, and currently they're being used in the Bonanza trial in traumatic brain injury. So we can see here, this is the screen on the device. So we can see concurrently intracranial pressure here. This is showing as 11. The oxygen within the brain is 9.9. So this is during the occlusive period or when the stroke is occurring. And the third reading is the temperature of the brain. So this is normal ICP at this stage. The oxygen is low because the middle cerebral artery is being occluded at this time. And this is normal temperature for a sheep brain. So hopefully next time we can provide a little bit more data on the comparison between invasive and the non-invasive. But as I'm sure you can appreciate, a lot of this data is proprietary at this stage. So that was a quick little drive through the Translational Neuropath Lab and what we've been doing over the past year. I gave you a quick overview of what's happening in terms of our studies in treating reperfusion injury following stroke, also looking at delayed neuronal loss and neurodegeneration following stroke, and a new and novel option for non-invasively measuring oxygen in the brain. A couple of other projects which are happening, which I didn't have time to speak about this time, are looking at blood and CSF biomarkers in stroke to guide treatment and maybe predict outcomes. We're also really motivated to develop meaningful preclinical hemorrhagic stroke models because there's a real paucity of these in the field. Also looking at portable stroke diagnostic technology, which can be taken to the patient anywhere, even in remote and rural locations. And the final one is collateral failure in ischemic stroke and how that can impact the evolution of the brain injury and therefore outcomes. We'd just like to acknowledge all of our collaborators, all of the students who've worked on these projects previously and currently, and acknowledge our funding partners. Thank you.